This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we're talking about nicotine dependency. Nicotine, that pesky chemical that makes tobacco products so hard to put down. The seemingly innocuous feel-good buzz provider that invites the more harmful chemicals in tobacco in. As a highly addictive substance, nicotine has been intrinsically tied to the conversation about tobacco use. But with the rise of vape culture, the conversation around nicotine dependence has changed. Often touted as harmless, tobacco-free nicotine products have existed for decades as tools to help with quitting. But why is nicotine itself still so hard to kick? To help us explore this chemical nuisance, our guest today is addiction specialist Dr. Robert Kirchoff from Mayo Clinic's Hospital Internal Medicine Department in Phoenix, Arizona. Dr. Kirchoff has a clinical focus on inpatient detoxification and withdrawal management and has helped many patients battle substance abuse and dependency. He'll help us to better understand nicotine dependency and the tools to help those who suffer from it. Dr. Kirchoff, welcome to the show.
Thank you.
Dr. Kirchoff, we are talking about a topic today that I have a lot of feelings about. I once loved and then lost a great relationship with nicotine. And it was not a great relationship because nicotine is not good for me, but I was a smoker for a very long time. And we're going to talk about smoking today, but not just smoking, vaping, nicotine in general. Let's start off with the basics.
Sure.
Most of us know at this point that nicotine is the addictive substance in tobacco. That's why cigarettes are so hard to quit. Tell us about nicotine. Why is it so addictive?
So nicotine is a really interesting chemical and drug. Most of the effects that it exudes in terms of its addictive potential are really related to neurotransmitters, which are chemical messengers in the brain, specifically dopamine, serotonin, and norepinephrine. And basically what neurotransmitters do is they allow the brain to send chemical messages throughout the brain for different processes. And one of the really important neurotransmitters involved in that is dopamine, and that's the reward pathway. And we see that as the central player in any addiction or substance use disorder, whether it's cocaine, alcohol, nicotine, or even process addictions like sex or shopping. So this is released when nicotine is in the bloodstream. Now, it's much more complex than that, but the gist of it is that this release of serotonin and dopamine is causing a reward sensation when nicotine is ingested. And in doing so, that makes us want to do it more. But it's not just a matter of getting a reward when we have it, but it's the bad feeling that you have in its absence, and that's called withdrawal. And that's really what keeps people smoking. It's the horrible feeling they have when they don't have the cigarettes available.
With nicotine and other substances like alcohol, we'll often hear the terms addiction and dependence used to describe someone's relationship to that substance. Can you explain how they're different and where they overlap?
So in the addiction medicine community, when we talk about dependence, it's a different thing than addiction per se. Dependence is a physiologic sort of process. Addiction, on the other hand, is more of a diagnostic criteria. So dependence is a component of addiction. Dependence means that you have ingested a substance long enough to the point where you've developed a tolerance to it, meaning your receptors in your body and the other processes that exist have adapted to the presence of this drug. So when that drug is removed, those adaptations that have been made are now going to lead to unpleasant symptoms. So just to give an example of another drug, if we have somebody who is dependent on alcohol, they're drinking on a daily basis, and when that alcohol is removed, they get very sick and they have seizures. Addiction, on the other hand, is typically defined as a continued use of a substance despite ongoing consequences and harm. And it's considered to be an organic problem. This is a neurologic chemical problem in the brain because of this imbalance of neurotransmitters. So part of the criteria is tolerance. Another part of the criteria is withdrawal. There's also continued use despite harm. There's a whole variety of boxes to check. And the more of those boxes you check, that defines the severity of the substance use disorder. The specific criteria for substance use disorder per the DSM criteria is you have to meet a minimum of 3 of the 7 specific features. Not all of them have to be checked. It just has to be by number, whether it's 5 or 7 or 9. This is defining the severity.
Right. There are a lot of serious lung issues associated with smoking that can sometimes lead to chronic obstructive pulmonary disease, or COPD, which basically is a collection of lung diseases that make it increasingly difficult to breathe. But smoking isn't the only way people consume nicotine. There's vaping, Zyn, chewing tobacco. Are any of these methods more likely to result in dependency or addiction than others?
It's really tough to say which one is more addictive than the other. I think a good way to look at it is how much nicotine they're getting per session. So with smoking, people might go outside, smoke, go back in the house. So they're getting their dose of nicotine going back in. Whereas with pouches and other means to administer nicotine, it can be done more discreetly. So you're getting a constant infusion of nicotine. And there's even these pouches now that are purely just nicotine, like the Zyn pouches that exist now. That's a pretty good dose of nicotine, and they're getting a buzz from that. They'll describe it as feeling almost like a little bit of a high. But what we see is as they feel that initially, they don't feel it a few weeks or a few months later. Now they're just using it to not feel horrible. And that is really the manifestation of tolerance. They have exposed themselves to this drug so much to the point where they're no longer feeling the euphoria of using it. They're just trying to stay afloat.
Are there certain people who are just more likely to develop dependency issues?
Yeah, there are certain genes at play that make people predisposed to certain substance use disorders. And there's also some genes that are actually protective against it. There's one particular gene that actually causes an aversion to nicotine because people don't tolerate it. Whereas there's also possible genetic variances that could make them more likely to smoke because they're metabolizing the drug faster and they're requiring more to get the effect. And we also see this in co-occurring mental illness. Very rarely does a substance use disorder, especially illicit substances, exist in a bubble by itself. A lot of times there's some other co-occurring psychiatric diagnosis that goes with it. Anxiety, depression, PTSD, and smoking is a way to self-medicate that. People feel that they're relieving some of their symptoms by smoking. So those are possible risk factors. But when it comes to like age and gender, it's not so much clear-cut.
You mentioned tolerance and how eventually when it comes to nicotine, a lot of people are using it not for the buzz or the euphoria. They're using it to tramp down on negative feelings or withdrawal symptoms. So if you are a regular smoker, is your body just constantly upping the demand of how much you need in order to stay at base level?
To some degree, yes. We do see a gradual increase in the amount that someone's smoking. You don't usually start off smoking a pack a day, but it usually plateaus somewhere, and usually that's limited by hours in the day and financial constraints. I mean, smoking is not a cheap activity, but most chronic smokers, the tolerance that they've developed to nicotine is palpable. It's very obvious because you never felt that buzz that you felt the first time in the same degree as you continue down with your nicotine use.
How would someone identify whether they've developed a nicotine dependency?
I think it's as simple as if you stopped, how would you feel over the subsequent days? Would you feel any symptoms of withdrawal? It could be subtle. It could just be irritability, maybe some trouble sleeping, just generally uncomfortable. It doesn't have to be as severe as full out nicotine withdrawal.
What does full out nicotine withdrawal look like?
So the main thing that we see with acute nicotine withdrawal, it's a full range of symptoms. Like I said, it's irritability, frustration, anger. Those are the most objectively observable features. People are just not in a good mood. We also see difficulty concentrating. So there's difficulties with cognitive performance, executive functioning, that sort of thing. People who have ADHD, their symptoms are probably going to be exacerbated in that setting. And by the way, people who have ADHD oftentimes are smoking to self-medicate through that as well. And with that, just as a side note, some of the medications that we use for ADHD also make people want to smoke more. So it's a double-edged sword there.
Wow.
But back to the symptoms of cravings and withdrawal. Increased appetite and weight gain is another one. We see patients that are on withdrawal, they're eating junk food. Why are they eating junk food? Because that junk food stimulates dopamine. It's giving them that little surge that they need. Sugary foods, fried foods, all that good stuff that we like, that we crave when we're stressed, while they're craving that twofold, threefold when they're in nicotine withdrawal. We see depressed mood as well. So those comorbidities that I had mentioned, the depression, anxiety, PTSD, those are going to be exacerbated because one of the drugs that they're using to self-medicate through those symptoms is now taken away from them. So those symptoms are all going to be exacerbated. So insomnia is part of it, restlessness, and then just a preoccupation and seeking of nicotine. They're thinking about it, they're craving it, they're probably dreaming about it.
Oh, yes, I've been there. I've done that.
Yeah.
Picking cigarettes from the cigarette tree and smoking them in my dreams. Yeah, I've been there. Using nicotine can make us feel so good because of the serotonin and dopamine it releases through our reward pathways. But there's another side of that coin too, the misery we feel in its absence. There's different levels of how reliant you may be on nicotine. If you're dependent on it, that means you've been ingesting nicotine long enough to the point where you've gained tolerance and adapted to it. And without it, you won't feel good. Addiction, however, means that you continue to use the substance even though you know there's going to be continued consequences and harm. Something to be mindful about if you do consume nicotine is that each method of ingesting it, pouches, vaping, smoking, or chewing tobacco, deliver different amounts of the drug. If you have a dependency on nicotine and decide to quit, you might feel withdrawal symptoms, irritability, trouble sleeping, general discomfort. But if you have it bad, acute nicotine withdrawal can be much worse, including irritability, frustration, anger, difficulty with cognitive performance and executive functioning, increased appetite and weight gain, depressed mood, insomnia, and restlessness. The risks of smoking are well documented. Lung and heart disease are the big ones, along with a cascading series of health fallouts. The best thing a smoker can do for their health is quit, but nicotine can make that really hard. So how are we supposed to know when it's the right time to ask a medical professional to help with that quitting?
If you're concerned about it, you should talk to your physician about it. And you probably should be concerned about it even if you're smoking a very small amount. Most of the time, it's the provider bringing it up to the patient. Smoking screening is a pretty universal thing now. Everybody should be asked about smoking at every encounter. As a hospital-based inpatient doctor, when I talk to patients about smoking cessation, they're usually worried about far bigger things because they're hospitalized. But a lot of times the smoking is the reason they're hospitalized. So that's a good opportunity for me to say, all right, I know you're here for this acute problem. I think we should talk about smoking cessation now. And since they can't smoke in the hospital, they're going to need to get nicotine somehow. So that's when I'm starting to offer nicotine patches, gum, lozenges, that sort of thing.
Those are still nicotine though, aren't they?
They are.
Like patches and so on.
Mm-hmm.
So how is that actually any better for somebody who wants to quit?
I mean, it's not ideal.
Mm-hmm.
Some would argue, well, you're just swapping one form of addiction for another, but a nicotine patch is far safer than smoking because the deleterious effects of smoking and pouches and chewing tobacco and dip are primarily related to the other carcinogens that are contained. So it's not the nicotine itself so much that we're worried about for harmful effects. It does have some side effects that can impair wound healing. It can cause issues with blood vessel constriction. But by and large, it's the carcinogens in the tobacco and the toxicity that it has on the tissues of the lung. Nicotine itself is not so much the big problem here, but it's the problem that it's what keeps people coming back.
Let's talk more about quitting. I can say for myself that I had to try a few different times to quit smoking.
Oh, yeah, it's very difficult. And most people have multiple attempts. People fail at it all the time.
What is causing so many of us to fail the first, second, third, 10th time we try to quit smoking?
So most of the time when people relapse on smoking, it's due to other factors. One, maybe stress levels increased. Well, stress is a trigger to smoke. They don't have the coping mechanisms to cope with the stress otherwise, so they start smoking. Smoking is an activity that is social, and it also co-occurs with doing other things. So they will say, oh, I was doing really well, and then I went out to the bar on Saturday and we were drinking, and then I started smoking again, because they've already associated consuming alcohol with consuming nicotine. And this is true for vaping too. That don't vape every day, they're vaping when they drink, they're vaping when they are stressed, they're vaping just when they're going out in social events or going to concerts, because this is what they've associated with those activities. And the brain ties those two things together. And that's when the cravings come in. You're in the situation, and in the back of your mind, you're sabotaging yourself, thinking like, okay, this is what I normally do. That would be really good right now. And then you watch someone else do it, and it's making you want to do it. So really, it requires a complete restructuring of life. It requires developing coping skills, even going to therapy. It sounds weird to say you're smoking, you need to go to therapy, but learning how to cope with stress will really help to reduce that urge to self-medicate with nicotine products.
Do you want to know what I did?
Yes.
I did a lot of what you're talking about. I deliberately did not go out for smoke breaks with people, which was sad for me because in my workplaces, that's how I met a lot of the people who became lifelong friends, was on smoke breaks at work. And I replaced cigarettes. Every time I wanted a cigarette, I would have a cup of hot herbal tea and I would inhale the vapors coming off of the tea instead. I also found an online support group, and anytime I wanted a cigarette or just needed some support, I would go on there and we would chat with each other and people would talk me down. And the way they talked different people down seemed to really vary depending on who was asking for the help. For me personally, one thing that really got to me was my vanity. I was not responding to, oh, you might get lung cancer someday. You might get high blood pressure someday. But when people said, here are before and after pictures of women who smoke after 30 years, that got to me. So what would you say to a young person or a new smoker who hasn't yet had to deal with any breathing or lung issues, or maybe doesn't see any reason to quit?
Most young people aren't going to identify with the 40 and 50-year-old version of themselves, because that's not what's immediately in front of them. But what is in front of them is the mirror. And if you can show them that before and after photo, you can show them problems with dentition, you can show them skin changes that occur, the rapid aging process. That can be a really motivating factor. But we know historically that shock and awe campaign for drug cessation doesn't work. DARE didn't work very well. It's helpful to provide education to kids, but scaring them doesn't really work that well. So it's much more nuanced and individualized. I don't think that there's a great answer. One thing that would be interesting would be to use like software to show them an older version of themselves of what they would look like with continued smoking versus not. I don't know if that's ever been deployed in a controlled way, but that would be an interesting study. Another thing to highlight is talking to them about their family history. Most people who smoke, their parents smoked or someone in their life smoked. They lost a loved one to lung cancer. They're doing something that's causing lung cancer. So that's one way that you can make it much more individualized.
And what about smokers who are a bit older and maybe they've been smoking for longer but haven't developed COPD yet and are otherwise healthy or think they are?
I'm going to point out the little subtle things that they may not notice. When you play with your kids or your grandkids, are you getting out of breath really fast? If I were to ask you to take 3 flights of stairs up to this appointment, how would you feel? And then I'm going to highlight that what's happening right now is an early manifestation of what's to come. This is a reversible process for them at this point. If you stop smoking now, you can get back to a normal quality of life. People quit smoking in their 40s and then start doing really high-end cardiovascular activities. They start running, they start doing things that they did when they were younger. The body is incredibly resilient until the permanent damage is done. So this is an opportunity for intervention.
And then for those smokers who have COPD and are dealing with chronic health issues, I imagine it's a lot harder to convince those folks to quit.
It is, because at a certain point, for lack of a better term, people will throw on the towel, be like, the damage is done. It is what it is. And to some degree, they're right. On the patients that already have emphysema, they already have COPD. The damage truly is done. It's not a reversible process. But when we stop smoking, we start to see improvements in cardiovascular function within the immediate weeks to months following. You can still stop doing damage. You can stop making it worse. There's always a worst case scenario than where patients are currently at.
The American Cancer Society says that the moment you quit, your body begins to recover. Specifically, 20 minutes after quitting, your heart rate and blood pressure begin to drop. 2 weeks to 3 months after quitting, circulation improves and lung function increases. Your risk of heart attack starts to decrease. And 15 years after quitting, your risk of coronary heart disease is the same as someone who doesn't smoke. How does the body turn all of that around like that?
It's just really a product of how resilient the body is. So we're talking the 2 to 3 weeks after we quit smoking. We've gotten through this period of withdrawal, but even in that immediate period when we're actively withdrawing, the body is still feeling improvement. We're seeing differences in gene expression even. And then when we get back into 3 months out, when the withdrawal symptoms have subsided, the mood disturbances are gone, and now smoking really should be out of the picture. That doesn't mean that cravings won't be there, but the true withdrawal will be gone. All the biomarkers that we see for like inflammation and the oxidative damage that we see from smoking, those are going to have a huge decline in that first 3 months. So that's where we start to see the cardiovascular recovery that they've mentioned. We see changes in heart rate variability, meaning it's much more consistent once you've stopped smoking. And as we progress into the upcoming months, we see that the inflamed tissue within the lungs has recovered, the lung elasticity has improved, and respiratory rate has probably gone down. People aren't breathing as fast because they're not struggling to breathe. Even if they don't realize it, these might be small differences in respiratory rate of 2 to 4 breaths per minute. But in the absence of smoking and this constant insult on the lining of the lungs, breathing is much easier.
The body's an amazing thing.
It is.
Why is it so hard to quit nicotine? Well, a lot of reasons. Stress, habits, and socializing, among others. Quitting smoking or vaping, or however you get your nicotine, really requires you to reshape your life. Therapy can be helpful to see if you've been using nicotine as a coping skill or way of self-medicating, and how not to. If you think it's too late to quit, it really isn't, even if you've already developed a chronic condition because of a nicotine habit. In fact, once you quit, your body begins to recover even as soon as 20 minutes after. So obviously, we know we shouldn't smoke, but for those who are out there who do smoke, who want to quit, want to know more about it, let's walk through some of the more specific steps. So we talked about nicotine gum, lozenges, and patches, and so on. I brought up the possibility that those could be addictive in and of themselves. How do you work with a patient to use that as a way to stop using nicotine as opposed to a way to get addicted to something new?
So nicotine replacement therapy is definitely tricky because you're still going to put them through some degree of withdrawal, but you're trying to minimize it by gradually tapering. So most nicotine delivery systems are going to come with some guideline, like, every week or two, you're going to cut back down to this amount. But one size doesn't fit all. So the first thing we look at is how much were they smoking? If they were smoking more than 10 cigarettes per day, we'll do a 21 milligram patch, and we'll do that for 6 weeks, and then we'll taper that every 2 weeks. Like we might say, after you've been on this for 6 weeks, let's go down to 14 milligrams for 2 weeks, and then let's go down to 7 for 2 weeks and see where you're at. With nicotine gum, we will do something based on the timing of when they smoke. So if they typically smoke right when they wake up, we give them a 4 milligram piece of gum when they wake up. There's also lozenges, same kind of approach. Nicotine inhalers, they come in different doses. It's a 10 milligram cartridge that we would typically use that gives you 4 milligrams of nicotine. We tell them to use that every 1 to 2 hours for a maximum of 16 cartridges per day. And we wean that over time. So tons of different approaches, lots of different products available. This is only one of the methods that we can use, but it tends to be the most popular, especially since they're available over the counter.
There's also medicines for addiction, right?
Yes. The primary medicine that we use for smoking cessation is Chantix. Varenicline is the generic name for it. It's a medication that works quite well. Sometimes we'll use that alongside nicotine replacement therapy, but the approach for that is really an incrementally increasing dose of this drug. So the first couple days we'll do a 0.5 mg, and then day 4 to 7 we do 0.5 mg twice daily, and then for the remaining 12 weeks we do 1 mg twice daily. If they've successfully quit smoking at the end of that 12 weeks, we'll probably recommend another 12 weeks of treatment at that same dose just to maintain long-term abstinence. But it's a pretty helpful medication. The big reason people stop taking it is nightmares. People have nightmares on this medication
Oh,
sometimes, and it can be unpleasant.
it reduces cravings, but may cause nightmares. Got it.
And people will say that smoking just isn't as pleasurable on this medication. It's what we call a partial agonist. It's blocking nicotine from binding to those receptors. So the smoking itself is not as pleasurable because the nicotine is not as activating.
Now, we've discussed support groups, we've discussed therapy. Do you have any tips for making the most of that?
There's no one size fits all to this. It really depends on the person. Some people respond well to group therapy, some don't. And this is true for all substance use disorders. You got to figure out what works for the patient and meet them where they are. Hypnosis therapy, some people find effective, others not at all. There are therapists that specialize in smoking cessation. If you can find one of those, I think that's great. But any therapy is good therapy, even if it's a therapist that just specializes in substance use disorders in general. The underlying process is really similar across all these substances. They're well equipped to help with that.
We would be remiss not to mention Mayo Clinic's dedicated nicotine dependent center. This is a residential smoking cessation program. Can you tell us about that program?
Yeah, that's a great program, and it's unique in that it is residential. They're taking a multimodal approach. There's group therapy involved there. I believe that there's individual therapy, basically helping to develop the emotional framework that needs to be there, the brick and mortar coping skills to help avoid a relapse.
Who would be the best candidate for that kind of program?
Well, that program is really best suited for somebody with early signs of development of comorbidities or risk factors for development of those. Patients who have asthma, who are smoking, they're continuing to use despite imminent harm. This isn't just long term. This is actively dangerous to them at the moment. There's also other conditions where smoking is incredibly detrimental. One of those is called Buerger's disease. That's a disorder where the vessels are actually affected so severely from smoking that you can lose limbs from it. It impairs circulation. So these are patients that would be good candidates. But anybody who is heading into a problematic range of smoking and having difficulty quitting, if they can get into a program like this, that's ideal.
So we've talked about quitting with the help of support groups, with nicotine patches, with behavioral changes, with lifestyle changes. Are there any lesser known tips for someone who wants to quit, practical or psychological?
I think it's very individualized, and it depends how much they smoked and what the circumstances were. If you live with a smoker, if your significant other is a smoker, it's virtually impossible for you to quit smoking if they're going to continue, because you're going to smell it on them. You're going to see it. It's just a recipe for disaster. So you both have to commit to it. Another tip would be to seek out other activities to distract from that. Pick up a new hobby. A lot of people take up running or exercise. Do something with your hands. People will utilize Jolly Ranchers, suckers, all the sort of physical activities that we've associated with smoking. Part of it is just putting something in your mouth. Drinking tea, as you mentioned, anything that has that sort of aromatic sensation, especially the herbal teas, mint, peppermint, anything that has that sort of inhaling, especially people that smoke menthol cigarettes, that's a big one. That makes a huge difference.
Let's talk about GLP-1 medications. They're primarily for people with diabetes, though they have become increasingly popular as weight loss drugs. And they've also been discussed as potential tools to help curb other cravings related to habits like hair pulling and skin picking. Could they be used for smoking cessation as well?
There are some pilots that have looked at using GLP-1s as an adjunct to nicotine replacement therapy that showed improved cessation rates and reduced cravings, and even some reduction in that post-cessation weight gain. These are limited studies. We're learning so much about the GLP-1s every day. They really are amazing medications, but I think down the line, this is going to be probably a pretty popular approach as an adjunct therapy for smoking cessation, especially since it's helping to alleviate the weight gain that people find concerning as they quit smoking.
So with all these methods in mind, where do people start?
There's lots of options available, but the take-home message here isn't memorizing the medications. It's go to your doctor and talk to them about options for smoking cessation. And just have that conversation and be mindful that even if you're smoking a small amount every day, this is still causing harm. And there's no point when it's too late to quit. The benefits will always be there.
That's such a note of hope to end on. Dr. Robert Kirchoff, this has been so fantastic. Thank you so much.
Yeah, you're very welcome. Thank you for having me.
If you want to quit your nicotine habit, what are the steps? Well, first things first, talk to your doctor. There are a lot of different factors that play into which route may be best for you. As for different methods, there's nicotine replacement therapy, which can use patches, gums, lozenges, even nicotine inhalers. Then there's the therapeutic route, including support groups, hypnotherapy, and even therapists who focus on cessation. There's also medicines for addiction, like Chantix and varenicline. The research on GLP-1s is limited, but so far pilot studies have shown that it can help improve cessation rates, reduce cravings, and even weight gain. Keep in mind, these are limited studies and that evidence will continue to evolve. Regardless of your path toward quitting, good luck. Okay, that's all for this episode. But if you've got a question, a topic suggestion, or a follow-up question about this episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Health Matters episodes and resources, head to mayoclinic.org/healthmatters. And if you found this show helpful, please subscribe and make sure to rate and review us in your podcast app. It really does help others find the show. Thanks for listening, and until next time, take care and stay healthy.